Becky. This is Don Getting, and good afternoon to everyone. I'm excited about the next panel discussion, which is talking about improving patient care through chronic care management and remote monitoring. We have three speakers on the panel, and I'll briefly introduce them, and then we'll get right into it. Our first speaker is Ryan Fox from AMC Health, and he's in charge of sales and provider marketing. Our next speaker will be Melissa Mitchell, who's the Chief Innovation and Strategy Officer for HealthLinc. And our third speaker is Jimmy McKanna, and he's the Director of Respiratory Therapy and Hospital at Home at Union Hospital. And I think he has a guest with him that he'll introduce. So at this time, I am going to go ahead and turn it over to you, Ryan.
Great. Thanks so much. Can you all hear me okay? Just thumbs up if you can hear me, I think. All right, great. Well, nice to see you all. Don, thanks so much for being our moderator here for our panel today. Really excited to talk to you all about remote patient monitoring. You'll hear the acronym RPM. Just for clarity's sake, it is remote patient monitoring or remote patient management that we're talking about today. There's still kind of some debate on the exact definition, but just wanted to get that out there. Next slide, Don. Great, thanks. So as Don mentioned, my name is Ryan Fox. I'm an Executive Vice President here at AMC Health. We are a 20-year-old remote patient monitoring company and solution. And over that 20 years, we've worked with federally qualified health centers, some physician offices, both small and large hospitals and health systems, big payers like United Healthcare, and also government programs like the Department of Veterans Affairs. And especially with the Department of VA, we've seen a lot of rural patients and veterans, a lot of socioeconomic needs, technological needs, and we've learned a few things about rolling out remote patient monitoring programs today. So I wanted to take just a couple of slides and kind of talk about some of the key considerations as you're thinking about remote patient monitoring at your system, and some of those things that you should be focusing on, or at least questions you should be asking both of yourselves internally and also of any potential vendor that you're choosing to work with. And then later we'll hear from both Jimmy and Melissa about some different RPM use cases and kind of their experience of standing up some programs on their own and the successes that they have had. So, there's a lot that goes into remote patient monitoring, and I think you can really boil it down to two simple facts that all of your considerations should come back to. One, there's a patient and you have to focus on that patient experience. And two, there's a clinician and you have to focus on that clinician experience. Both are equally as important. You have to make the technology easy for the patient to use, the solutions to meet the patients where they are. They come with a wide range of socioeconomic factors or challenges, technological needs, patient preferences. Maybe they come with multiple chronic conditions. And so you have to have support built all around that patient experience. So things like, technological preferences, for example, maybe they don't own a smartphone, but maybe they're comfortable with technology. Does your proposed solution offer multiple different ways to try and engage with that patient and recover some data back from them? At the end of the day, it's got to be easy. If it's too difficult, the patient's not going to do it. I think I can't see anybody's videos at the moment, but I would suspect that some folks are probably nodding their head yes on that point itself. Accommodating for a wide range of conditions. So often in healthcare right now, especially as the COVID-19 pandemic rolled out, we were very focused on COVID-19 monitoring. We were very focused on some of the chronic conditions like heart failure, COPD, et cetera. But we're also recognizing that patients are coming with a host of behavioral health issues, or maybe there's other types of use cases that exist above and beyond just those standard chronic conditions. And so looking at solutions that have options for multiple different chronic condition types that patients come with is going to be critical, especially as you look to scale some of these programs above and beyond a pilot type of implementation. Also, patients are coming with a variety of different acuity levels. So maybe there's a deviceless type of approach that you want to take with low acuity patients. Here on the screen a few minutes ago, we saw an example of a flow sheet looking at some SDOH type of information. What if you just simply want to try and engage with patients and recover SDOH answers from those patients in a very low tech, low touch type of methodology and pull that into a platform? It could be an approach for both low, moderate, and high acuity type of patients, and looking at solutions that offer that flexibility is also important. We talked a little bit about making the technology easy to use, but I think this goes above and beyond just simply, do you have a smartphone app or a tablet or a modem? It also accommodates for things like patients that maybe have trouble seeing, and so can you change the font size or change colors? And making some of those applications more ADA compliant as well are some important considerations to pull in here. Logistics of the devices kits and subcontracting, or are those in-house? This is a big issue right now within remote patient monitoring. We've had some supply shortages. The pandemic certainly contributed to some supply shortages. And there's some RPM platforms out there that maybe don't have local inventory on hand, and instead they're drop shipping. It creates some bottlenecks. There's such a crucial gap in time between when patients are being discharged from the hospital, going home, and becoming comfortable, that if too much time passes, you might have kind of lost your window to continue that engagement with those patients. So looking for solutions where they've got a good, robust logistics warehouse facility is also something to keep into consideration. And then the last point here on patient experience is that patient engagement is not just a one-time thing. It's a tough thing, and it is something that continuously happens over a very long period of time. Many of these patients that are living with chronic conditions, there is no fixing their chronic condition, and after 3-6 months of monitoring their conditions, they don't just become solved at that point. It's really an ongoing educational type of process with these patients, and getting them to a point where they've better learned how to manage their chronic condition or their disease, and live a happier, healthier life. So there's a lot that's kind of baked into that patient experience piece. The next one here on the clinician experience, and I won't go through every single data point here just in the interest of time, but this is a very critical aspect here. Making it easy for the clinician to absorb all of the data that the patient is responding to, looking at trending over time, integrating that into their clinical workflow is probably one of the single most important pieces here to this. Last thing you want to do is contribute to any kind of alert fatigue or additional data that's just noise and not actionable. So really trying to figure out, well, how do we make the most sense out of the data points that are being collected, and how do we intervene or act upon that data in an easy way for the clinician is also important. And there's a couple different ways or a couple different things to kind of look at in this. One is the platform that you're going to utilize, does it enable some real-time clinical decision-making? Has it been reviewed by the FDA as a Class 2 software as a medical device platform? Are there any kind of EMR integration points where maybe you can point and click to auto-enroll or auto-disenroll patients out of the program? The last thing that the clinicians are wanting to do is go to another third-party service, utilize a third-party service that doesn't have some kind of integration back into the core EMR platform that they're working with. And also billing is important to consider too. You've got to provide some support for those Z codes, the CPT codes, any kind of fee-for-service reimbursement that you may be seeking for those programs, but also support any type of value-based care programs that you have out there. And then the last point on here is just the various degrees of clinical staffing that would be required to provide some oversight. As patients come in all shapes, sizes, and clinical needs, there may be different approaches to who provides that kind of clinical oversight for those patients. Next slide, please, Don. And a couple other considerations here, really, just as you're going through and kind of vetting and thinking about your long-term virtual care strategy. I wanted to put a couple other items on here to keep into consideration. Does this solution have some proven successes already? There's a lot of RPM companies that popped up over the last couple of years, just largely in response to the CMS fee-for-service codes that came out. But maybe they are, a point solution. Maybe they can't scale beyond just heart failure, for example. So looking at, do they have some proven and validated studies or outcome data out there? Have they been proven to scale their programs? But then also, you really need to kind of step back and take a look at what are some of your clinical goals, or what are your financial goals? What do you want to achieve out of an RPM program? Those are important, not just from a short-term, but also a long-term perspective. And I think you're going to hear some of that from both Melissa and Jimmy and Parrish here in a few minutes. And then patient onboarding. So as you're talking about kind of trying to better understand who the patients are, what their socioeconomic factors are, their statuses, their clinical conditions, there's a lot of work that needs to go into that onboarding. It's not just as simple as sending a patient a blood pressure cuff and saying, okay, start taking your readings every other day. There's a lot more work that needs to go into that onboarding. So ask a lot of questions around who does this onboarding. Is it on the hospital side? Is it more on the vendor side? Is there a blend between those two? And what does your process look like? How do you engage with those patients for that onboarding? Getting that right off the bat is going to lead to better engagement from your patients and better successes and better outcomes for your patients over time. The last couple of questions here are really just around painting a better picture of how broad this solution could be. Do you have reporting capabilities? Do you provide any type of analytics on the data? Can you help me better understand the data that I'm collecting and make sense of that data so that I can be more impactful on my unique individual RPM program? With that, I will pause there. I think the next speaker is going to be Melissa Mitchell with HealthLinc and FQHC out of Indiana. So really excited to turn her over to you, Melissa and Don, and hear a little bit more about your program.
Thank you, Ryan. Melissa, go ahead.
All right, thank you so much. And thanks everybody for having us here today. If we want to just go right on to the next slide, I'm going to talk a little bit about the perspective in terms of getting a program started. So the first thing that we really had to look at was, how are we going to fund this? You know, these devices, they're not free. The process isn't free. So how are we going to look at that? So what our intent was we are going to look at ways to get some either grants or different programs to help us to get these devices into our patients' hands. For those of you who don't know, FQHCs generally have a population of uninsured or underinsured patients. So we need to get this at the lowest possible cost for them. So we reached out to the FCC and we were given some dollars to acquire some devices. At that point, we had to determine which were the devices we needed to serve the populations we were focusing on. We decided to focus on things like congestive heart failure, diabetes, a lot of COVID post-hospital patients at that time, and then just general patients that we had that were high risk that needed a lot of basic care. So we went with the oximeter, your blood pressure cuff, scale, glucometer, and a thermometer. We decided at the point that we rolled these out that we needed to get the devices that best integrated with our EHR software at the time. And those happen to be cellular technology devices. So what that looks like is that they don't have to do an individual connection with any of their devices at home that are on Wi-Fi, anything like that. But anywhere that there's a cell signal available, these devices can go ahead and transmit without having to log into anything. We paired that with a company called MD Revolution. That's the backbone of this information for us, so we're able to see everything on. And the reason we went with the cellular devices is we had already had some other RPM devices through a pharmacy program that were Wi-Fi, and we wanted to take this opportunity to test out something different and see if we were going to go with one or the other in more long-term projects. So it will help us to understand a little bit more, we hope, about the digital literacy of patients, especially patients that are already pretty sick. So we're hoping to get some good data on that as we move through the project. Okay, next slide, please. So what we ended up doing after we were awarded that FCC set of dollars was we realized that, well, who's going to read these devices? Who's going to be responsible for tracking all of this data that we used to only get when a patient would come in and bring their paper log? And so we started applying for some other grants, and we've had some great success with the state. We're very grateful for the opportunity they gave us through another grant that's going to support the RPM devices. So we wrote into that grant basically the who and the how was going to do this. So we chose those two things and then wrote for the grant and were awarded it. And so now, if you're keeping track, we have the devices and we're going to have the people and staff and processes to do that through another grant. Well, it was at that point we noted, okay, well, this is all good. And a lot of our patients are going to give us these numbers and then we're going to be able to read them. And then we identified that, well, what are we going to do about it? As an FQHC, we have clinical pharmacists in our offices that work with our patients. They titrate meds, they talk about diet, but then we realize that a lot of our patients, for the conditions that they have that we're trying to take care of, are not bringing in the right kind of nutrition to do anything about those long-term anyway. So we decided that we wanted to stack these opportunities with another food as medicine opportunity that we were ultimately awarded through Anthem, well, Elevance now. And so now we're taking these projects and combining the devices with the who and the how, and now it's the then what. So for our patients who have food insecurity or nutrition insecurity, we're going to tackle that through our food as medicine part of this project. And with all of these, we decided we're going to write for a clinical researcher so that we can prove out throughout the tenure of this project that we're really able to make a difference by knowing what's happening with our patients, giving them the people that they need to talk to engage in their own health care, and then helping them move forward with how to take better care of some of their disease states by everything they're doing, not just the things that we can prescribe them at the office. We're going to just get started on this, so I don't have all of the results and the end reports for you today, but I'm hoping if we come back and we have another conversation in a year, I'll be able to just show some really powerful data on how having all this knowledge and being able to do something about it gives us a way to help our patients take better care of themselves. So we'll do that through continuing to pursue additional foundations or funding as we understand what our needs still are. All right, next slide, please. Okay, so now we have all this. We've gotten all these grants and we're putting them all together. And from our perspective, we have to do the work now. So the first thing that we had to do as we got started was develop the project team. And we want these to be different roles and responsibilities around our entire organization. So we have our director of nursing, we have our provider clinical engagement team, we have the IT team and our outreach team, and everybody who is eventually going to have to touch this project or any of these patients with it. They need to be aware of what's going on, and we want them to have a seat at the table while we're developing it. If those people don't exist yet that we need for this project, then we have to hire them. Back to that grant that we got through the Indiana Department of Health, it called out people. Some of those people we have in our operation right now, and some of them we don't. For instance, we have to hire a dietitian. For an FQHC, that's not billable for us right now, so we were never able to have one before this project, and we're really excited about that opportunity. The next thing we had to do was develop the eligibility guidelines, both for the patients and staff. Are there certain provider types that we want to have referral into this program first? Are there certain patients that we need to include and exclude due to the length of the project that we're going to be working on here? And so a lot of insight and time was spent determining the best way to get a patient in or out of this program. After we determine all those things and get all the devices and have all the setup ready, we have to create training, not just for our staff, but also for patients. And then we have to create training in multiple languages, and we have to create training that is culturally sensitive and make sure that we're addressing all of those things that go into the daily life of a patient and make sure that we have that ready for them. As with everyone, always, we have to check and make sure that our EHR can document all of these things that we're going to be studying. Many of your EHRs, probably the same as ours, do not have very specific food-based qualifications in your EHR. So some of this we're going to have to build out and create on our own so that when we get to the end of this, we can really create strong data and stories about what food interventions made a difference and how, in some cases, if we could put them on a low salt diet and then watch how that affects their blood pressure on the daily RPM device, it's going to really help us to understand what patients need which interventions as we move forward. So right now we're in our testing phase. We've started to roll out the RPM devices at some of our more rural sites so we can understand a little bit more about what troubles we might come into right out of the gate. And so we found a few, rural places don't have the best connectivity in every location. I know even in my own home here in rural Indiana, I can't always get cell phone signals. So our patients experience the same things, and what do we have to do to overcome that? Once we understand all that, we are going to start scaling that out to our entire organization. Our goal on this is at least 1,000 patients, so we have a really good, deep level of information on each patient. We'll be able to understand that a little bit better. Okay, next slide. Okay, so I know that we are tight on time today. That's just a little bit about what we've done to start the project with RPM and HealthLinc. And I think now I'm going to turn it back over to Don, who's going to introduce us to the people who are going to tell us more about what happens when you get results. So I'm super excited about that. Thank you, guys.
Thank you, Melissa. I'm now going to turn it over to our presenters from Union Health, Jim and McKanna, and his special guest there. So go ahead, Jimmy. I'll let you make that introduction.
All right. Hey, I'm really excited to be here today, and I hope that our pilot that we did over 6 months is able to be replicated. But I'm going to go through it real quick. This is boots on the ground type stuff that we did. Started it early last year or late last year, and looking specifically at heart failure management with remote patient monitoring. All right, next slide. All right, awesome. So why do we pick heart failure? Well, just to be real honest, the hospital has difficulty with readmissions in this area. This is a difficult disease process to treat, and it's not going anywhere. As you can see from American Heart Association on the screen, currently 6 million people are affected by it, and it's expected to be 8 million by 2030. And our community here in Terre Haute is not immune to that, and is actually quite high in this area for heart failure. So our readmissions were going up. We were seeing a lot of patients in the hospital with this, and we brought remote monitoring in and said, how can we use this to affect our patients, not just for readmissions, but also for their overall quality of care and them taking care of themselves at home. And we use a little bit different process. So next slide, Don. All right, so our 6-month pilot we did with population health, better go back, there we go. With population health was outpatient care management. So what we did, and I tried to make a picture here to depict it, we had a nurse navigator in the center of this, working specifically with our RPM company and our patients at home. We picked 14 specific patients and these were not easy patients. They were difficult patients. They were picked by our cardiologist. We have one champion cardiologist who's really interested in this. So you pick some patients that were population health and just heart failure. Out of them, we're using Blue Star. It's a telehealth service off the East Coast, veteran owned. And they do ship the items to the patient's house. We identified the patients. We started them on remote monitoring, looking specifically at weight and their blood pressure. But we were a little bit different because having this nurse navigator in the middle, we got to be much more aggressive with the management. And I'll have Paris talk to that in just a second. But I mean, even day to day, making changes in medications using the cardiology providers, nurse practitioners, and PAs that work with that cardiologist, able to change the patient's medication and never actually come into the office, and then monitor the changes that are being made with blood pressure, the blood pressure cuff and the scale, you know, every day, so that we're able to keep these patients at home and also manage their disease process. Next slide. All right, some successes. I'm going to turn this over to Parrish to kind of talk about this a little bit. Parrish has been a nurse since 1992. He's worked in almost every department of the hospital, intensive care, ER. He worked in echo, vascular ultrasound technician for a long time. He's an instructor of multiple things. And here's the great thing about Parrish. He was willing to jump into this technology area with us for this short pilot. He is now a population health nurse navigator. I'll turn this over to Parrish.
Hello, everybody. Let's try it here. Pretty amazing. But just got some highlights. The remote patient monitoring of the blood pressure, heart rate, and weight for signs of volume overload or depletion allowed aggressive management by our team in the home. As many of these heart failure patients are medically complicated, RPM was useful when adding the SGLT2 inhibitors such as Guardians or Farxiga, and decreasing loop diuretics safely and effectively for patients. The PCPs recognize the increase in collaboration between themselves, cardio, and pharmacology during the population remote patient trial. We also observed with RPM and CCM, the relationships you develop makes a closeness that allowed us to open up discussions with some of these truly sick end-stage heart failures with palliative care and end-of-life planning. 6 of our heart failure patients were referred to cardiac rehab, which is good as far as revenue goes, but also the patients really enjoyed the social interaction. And just a lot of these heart failure patients, just the understanding of what their exertion limits were, and felt a lot less anxiety with being active, you know, in the home and in their daily activities. Once RPM initiated, we did basic heart failure education. We reinforced this with a clinical dietitian. She would focus on low sodium heart, healthy diet, and education meal plans. 3 of the patients specifically noted marked improvement in the quality of their life. They noted that the RPM allowed them that real-time, quick data back to them as far as with weight and blood pressure when they would break their diets and go back to kind of a higher sodium diet for meals. So this is a great effect of what RPM can do in working with the in-home management. We had a 79-year-old male. He was 310 pounds when we received him, severe volume overload. He was on Lasix 40 milligrams Q-day for multiple years. He changed providers to our cardiac team. Remote patient monitoring was initiated. The aggressive medication management, education, lifestyle modification was provided. Patient as of today is down to 268.3 pounds. When this started, he was short of breath with ADLs. Presently, he is volunteering at the local food pantry, and he is doing remodels with his nephew, kitchens, bathrooms, etc. So essentially, it really truly gave this man his life back. And we had 1 admission in 6 months. And then since then, we've had a couple that were not secondary to the heart failure. And outside of that, we have been ER and admission.
All right, so how do we plan on expanding this? So starting with a pilot is great, and I forgot to mention this was funded from one of our hospital foundation some local money that we have to go and ask for and show a business plan. So we wanted to start with this and expand to other areas. So as you see with my model here, Don, if you want to hit spacebar again, we want to expand this to RPM, not just to just heart failure, but to other areas, pulmonology, outpatient, diabetes, all these different other patients we can expand this to, and expand it with heart failure. And that's what this kind of shows. We have a nurse navigator in the middle, and our ultimate goal is not to have a cardiologist managing all these patients because they don't have the bandwidth. I'm sure yours doesn't, ours doesn't either. But our goal is to have this connection between cardiology providers and the primary care providers as a part of this remote monitoring team, so that the primary care providers can see these new ways of managing heart failure, and they can see the quick response that these patients are getting, and then change their practice or update their practice so they can manage these patients in their practice. Because that ultimately is the goal, and it's something that we really should be doing. Cardiologists don't have enough time to do all this. They have tons of procedures and other things they're doing, but to be able to go across those different disciplines from cardiology, primary care, and then also you'll see in the corner I have our outpatient care management team. So this is our population health team that can take and wrap all the other services that this patient might need, since they're on remote monitoring, wrap these services around them so that we can really help them with their disease process. But the ultimate goal is so that they can self-manage. So give them all the tools that they need so they can self-manage, and they can manage their disease 100% on their own. It's not our goal to keep monitoring them for a long period of time. We want them on their own, knowing what they need to know to manage. Next slide. And this is what this is all about, wrapping our services around the patient. And the great thing that we allowed our patients to do during this time was they could contact that person that's in charge of remote monitoring, and they could get assistance with different things as far as getting in their specialist or other appointments, or they could ask questions to that nursing team. So it was the opportunity that we had for them to buy into it, because a lot of patients didn't like the fact that we might be monitoring. Big Brother's watching them from above. We gave them these incentives to say, if you're a part of this program, we will then be able to, kind of work back roads for appointments and whatnot, which we know that we could do from the hospital and outpatient setting. Next slide. Awesome. So, and we're open to any questions that might come after this, but we're extremely grateful to be able to present what we're currently doing. We also are doing this with hypertension and managing chronic hypertension in patients, and working with family physicians in that area. So the area of remote monitoring has just barely been touched with heart failure. There's so many other applications across the spectrum where this could be used and benefit our patients.
Great. Thank you so much, Jimmy and Parrish, and to all of our speakers on our panel today. Becky, I don't know if we have time for questions now or if we'll handle those offline.
We're over on time because the previous presentation went a little long. So I think what we'll do is I have my email in chat, and email any questions and I'll connect with the panelists and we'll get answers right back to you. A lot of good information shared, but I believe we'll go ahead and break for lunch as we still have a full afternoon. But thank you so much, team, for the presentation. Great information and very inspiring, and really some good work in progress. So at this time, I'll turn it over to Brent just for an exercise to promote your wellness, and we will resume at 1:15 to have a discussion around recruitment and retention of providers and critical access hospital staff. So thank you all so much.